Thank you so much for joining us today. This is the re-record of ShakeOut Your CMS Emergency Preparedness Exercise Requirements. I am Nora O'Brien of Connect Consulting Services. Joining us today is our esteemed colleague, Mark Benthian from the Southern California Earthquake Center, and talking about the Great ShakeOut. So what we also have is, during the presentation, we got a ton of questions on GoToWebinar. We are going to take those top questions and share those answers at the end of the presentations.
Hi, everyone. This is Mark Benthian, and I'm really excited to talk to you about ShakeOut. Great ShakeOut earthquake drills are happening this year on October 17th, but you can participate and have an earthquake drill any day of the year that will satisfy your requirements. Schools, organizations, families practice earthquake safety and other aspects of their emergency plans as part of ShakeOut. Most will participate in a drop, cover, and hold on drill, which I'll describe. That can take as little as 1 minute, but many do much more. And of course, for your CMS requirements, you will need to do more than the basic drop, cover, and hold on drill. The first ShakeOut happened back in 2008 in Southern California, and it was really meant to be a one-time event, but because of requests from other states, other countries even, it has expanded and continued. And in 2018, there were more than 62 million people worldwide engaged in earthquake preparedness drills, practicing earthquake safety. The International ShakeOut Day for 2019 is on October 17th. It's always the third Thursday of October. And you can go to shakeout.org to connect to your local ShakeOut region and learn more. Most people might think about earthquakes being just a West Coast issue, but really they can happen in nearly every state, and maybe not as frequently as in the more active areas like the West Coast or Alaska, but there have been large earthquakes, such as in the central US, the New Madrid earthquakes in the early 1800s, in South Carolina in the late 1800s, and elsewhere. And of course, there was a big earthquake on the East Coast. Well, it was felt across a large part of the East Coast in 2011, centered in Virginia, but felt very broadly. Why do we say drop, cover, and hold on is the recommended action to take during an earthquake? Well, a lot of what causes injuries is people being thrown to the ground, from falling and flying objects, and people getting hit by when they're running outside, which we do not recommend, but things are falling off the buildings, glass, bricks, and parapets, and other aspects that can, or items that could be on the sides of buildings, even when the building would never even collapse itself, and which is actually quite rare. So even our urban search and rescue firefighters that have rescued people from earthquakes around the world really do say that this approach is the smartest way to make sure that you're more likely to be safe during an earthquake. So in most situations and in most building types, you're going to drop onto your hands and knees where you are. That means you're not going to run down the hallway to some place that's you think is safer than where you are. That may put you in more harm by moving, especially maybe if it's the earthquake happens at night and you don't have your shoes on, there may be broken glass, but also it's just the act of moving during strong shaking. You may be knocked down, or other items may be being thrown at you or falling onto you. Once you're on the ground, you actually want to immediately cover your head and neck with one arm and hand. It's kind of getting that arm up and over to protect as much of your head and neck as possible. Kind of you're bending over as shown in some of these pictures. And then if a sturdy table or desk is nearby, crawl underneath it for additional shelter. If there is not a table or desk or something you can get under, you can crawl against a wall, preferably a wall without windows and glass, or next to low furniture basically you're protecting yourself from one side when you're doing it. You're limiting the way that things can be coming at you. You're making yourself less of a target. The ideal situation is to be under something so that things are not even able to hit you from above. And then once you are under or covering yourself, if you're under a shelter, hold on to it until the shaking stops and be ready to move with that shelter. This is why we encourage people to be bent over kind of on hands and knees, well, not on, at least as shown in the picture here, because you got to be ready to move. So you don't want to be laying down or sitting down. You want to be ready to move as needed because the earthquake may be shifting things around. And then if you're not under a shelter, hold on to your head and neck, cover it with both arms and hands. Again, get your elbows up above your head as much as possible and your arms covering your neck, your hands covering your neck. And then earthquakecountry.org/step5 has a lot of advice for a variety of settings, including if you're someone who, if you got down, couldn't get back up. And in that case, you want to bend over where you are and cover your head and neck like if you're seating, and cover with your arms and hands. If you're someone who maybe uses a cane, a walker, or a wheelchair, or you have patients who do, we have guidance there as well. With people who use a cane, you want to keep that cane with you to be able to use it to get back up again. If you're using a walker, like a rollator that has a lock, you can actually lock that lock, as well as if you're in a wheelchair, so that the wheels don't be moving, are not moving around. And then if you are able to bend over, cover your head, and if you have something like a book or a pillow, put that up over your head, just to provide more protection from falling objects. And we have more information on this, as well as other topics about earthquake safety for people with disabilities and other access and functional needs at earthquakecountry.org/disability. The other key aspect that's on this slide is that you want to instruct others how to assist you if you're someone that uses a mobility device or may have issues performing this activity. For example, you don't want someone who's in a wheelchair, you don't want someone to come up to them and drag them out of their chair onto the ground, thinking that they're providing assistance and making them more safe. That might cause injury. And practicing this is key. We also have a series of videos that show what to do during earthquakes and on different topics. And you can view these on our website at shakeout.org/messaging. You can actually download them. You can also just view them on YouTube at youtube.com/greatshakeout. Note that we have a video also for various situations, but also for people with mobility disabilities that shows people using their actual devices that they use day to day, practicing how to be safe during an earthquake. So we have like 6 or 7 different situations there, different types of devices. I should say that's a great video to show if you have patients in your facility who use such devices, to instruct them for what to do, as well as your staff. We also have a poster that can be ordered from FEMA, and you call this phone number 800-480-2520. Ask for FEMA publication 1078. And this poster shows different situations, 9 different situations for how to be safe during earthquakes. And really is meant to make you think about what should you do no matter what your situation is. I think you can get something, you can ask for something like 20 copies of this. It's great for putting up in employee break rooms or other places where people can really take time and look at it. All right, so ShakeOut's goals, really from the bottom up, our main activity is to encourage people worldwide to practice earthquake safety. That's kind of our basic goal. But what we really are trying to do is shift the culture, getting people really thinking that earthquakes are things we can prepare for, that we should prepare for, and that it's possible to prepare for. And therefore, and that's really the case with all things preparedness, that it's possible that anyone can get prepared and it's a good thing to do. And from that, we'll have increased resilience at all levels. And that really is our ultimate goal that we're looking to achieve. And everyone can shake out. This is a collage showing people from many different sectors participating in ShakeOut. People have fun with ShakeOut. You know, it's a serious concept, but practicing doesn't have to be all serious. The women in the top left have created their own ShakeOut t-shirts with martini glasses that say shaken, not stirred, and you know, as a bonus to their activity. The group in the center is at a church practicing drop, cover, hold on there during a service. Of course, young kids in a preschool situation, CERT teams practicing how they would provide medical care, and fire departments as well. And also in the lower right, the pictures from a long-term care facility where patients were shown how to protect themselves and then brought outside to make sure everyone was okay and to provide then practicing going in to perform search and rescue as needed. ShakeOut, as I said earlier, started in California in 2008, but has grown across the country. And we actually have custom websites for 20 different regions across the US. Some are multi-state regions, such as in the central US, the Southeast and the Northeast and the upper Midwest, while the West Coast states and territories and islands in Hawaii are individual websites. So you'll just go to the shakeout.org webpage. There's a menu at the top of the page, or you can scroll down and click on your region to get right to the custom information for you. We also do have information in shakeout.org/Espanol for Spanish and for other countries and other languages. The ShakeOut website has a lot of great information for what to do, and we'll cover some of that, but also has a registration option. And this is where we really understand who's participating, what they're doing, and where they are and what types of organizations. And you really get to be counted in the world's largest earthquake drill, which for some people is fun and exciting. And it's also a way of having your participants in your facility understand that it's not just you telling them to do this, but it's part of something that's not just in your region, but it's actually worldwide that they're getting to be a part of. You will get updated news and safety tips via emails that you can opt in to receive. You'll be listed with other participants on the website, which I'll show, and that's also optional, but a lot of people really like to see their organization listed because that really helps you be an example that motivates others. We have heard people have told us that because they were able to show the list of participants to their leadership of their organization, they got to go ahead to participate and have earthquake drills, to take the time out of the workday to do that. People have told us that by participating and taking action and by registering, saying, yes, we're doing this, that provides a certain peace of mind that they're taking action that will help their organization and their employees and their patients and just everyone be better prepared to survive and recover when the earthquake or other disaster happens. Because really, while this is about earthquakes, this drill activity prepares you for many types of disasters that can occur. You're practicing, you're having conversations, you are thinking through how do we be better prepared. Now, finally, this registration process itself does not complete the CMS requirements. You also need to do an exercise. And there is validation of your reporting that will be happening through surveys and other activities. So this just shows that we have statistics of participation for all the different regions. When you go to a particular region, you can see it by category. And then once you get there, you can see the listing of those participants. One thing I like to point out that I did in the live webinar is that I see in the business area there listing, I do see a couple listings for DaVita Healthcare, and that is a question we get sometimes. We are a business, but we're also healthcare, and you really want to lean towards the more distinctive category that you are, which I think in this case would be healthcare. Businesses are really more kind of what we're thinking of in stores and companies that are selling products and other types of business. We have many ShakeOut resources available for you. For some reason, this slide has not come through too clear, but the resources themselves are. And we have posters that you can display, you can print and display in your facility leading up to the ShakeOut and on the day of the ShakeOut. They can be printed at any size from 8.5 by 11 up to a big poster. We have web graphics shown in the lower left that you can put on your website and use in your emails. We have single sheet flyers for different categories, including for healthcare, and other types of guidance, including manuals for how to conduct your drill. We also have resources to help you communicate about what you're doing internally and externally, from even press releases that you might want to do if you're really doing something interesting and big, and you might want to have even media come to see what you're doing and show off what you're doing. Also, downloadable videos, animated GIFs for your social media or for your internal communications. At shakeout.org/healthcare, there's a great amount of information that may be useful for you, including overview of the CMS Emergency Preparedness Rule and how it can be applied for ShakeOut, a ShakeOut manual that also has that information and provides different levels of drills that you can do, that really it's level 2 and level 3 that are going to be counting towards your CMS requirements. Just doing drop, cover, hold on its own will not. And there are other resources for healthcare organizations on that webpage. You can connect with us via info@shakeout.org. You can follow us on social media on Twitter and Facebook. And if you have an urgent question and you want to call, you can call 213-740-3262. You can also email me directly at benthian@usc.edu, and my Twitter handle is Mark Benthian. Now we'll go back to Nora O'Brien to hear more about how ShakeOut can satisfy your CMS emergency preparedness exercise requirements.
I want to say thank you so much, Mark, for that wealth of information. You just about ShakeOut, and I'm just ever more impressed with the work that you all do every day of the year, and not just on one day of the year when the ShakeOut happens for a lot of people. And Mark wanted to remind me that you can do the ShakeOut at any day of the year. So these resources are ever important, because unfortunately, those earthquake risks that we have can happen at any time of the year. So now I'm going to be talking about ShakeOut your CMS emergency preparedness exercise requirements. We're going to talk about what CMS says about exercises and review on a small scale what the requirements are, but delve deeper into those exercise requirements, and hope to give you some strategies and some tools and some opportunities and resources to help you meet those requirements. Okay. All right. So again, I want to reiterate, so both Mark and I learned when we did the webinar last year that we got a lot of calls and that we had to field the day of the exercise or right before ShakeOut about really clarifying what their role was, because we found a lot of organizations that for the most part just have not participated in the ShakeOut before, and it was new to them, and also the CMS exercise requirements were new. So with the new experience came a lot of questions. So the CMS emergency preparedness clarifications. So it does not count towards your exercise requirement, just registering for the webinar. A lot of people said, I need my certificate that I was on the webinar because that proves I conducted my exercise. And we said, no, that is not the case. So we appreciate you came to get this information, but that's the clear. The other thing is registering, if you just register for the Great ShakeOut Earthquake Drill, that also does not count towards your exercise requirement. And also underscored by Mark, what does count towards your requirement is you complete the drill or exercise if you want to do it as a tabletop exercise, if you want to do it as a functional or a full community-wide full-scale exercise, however, whatever kind of level of play you want to do, you have to complete the drill and you have to complete an after action report, because what CMS wants to see is, if you didn't write it down, it didn't happen. When surveyors come to visit you, they're going to want to see that after action report, which we've provided to you all. So there's about the clarifications. Okay, I'm going to talk a little bit about what those requirements are. What the intent was not to just add more requirements for, as healthcare providers, you have plenty of other things you have to comply with. But what CMS was looking for when they came out with proposed rule in 2013, finalized in 2016, and gave until November of 2017 for all 17 provider types, a total of 73,000 providers of hospitals and long-term care and primary care and ambulatory surgical centers, etc. But what they were looking for is bringing the same standards that many Joint Commission hospitals have met around developing plans, developing communication plans, etc., and bringing up to the same standard. Because what CMS was looking for was better patient outcomes. We all saw Hurricane Harvey. We've been watching the news related to Hurricane Dorian. What we know in disasters, if you don't have plans to know what to do, if you don't have communication tools available to you, your patient outcomes, are at risk. And those folks, whether they're old or sick, related to Medicare or Medicaid, they're more vulnerable in disaster. By shoring up you as organizations to plan and be better prepared for disaster, the intent was to get better health outcomes for those patients. So the link here, the hot link, is at the top, the CMS Emergency Preparedness Core Requirements. That is straight to the CMS website, so you can believe me or just go straight to the source of CMS. But what are the 4 things they said everyone must have is you have to develop a plan based on a risk assessment. And the risk assessment looks like it's both to your facilities, but also to those facilities, but also to your community. What I mean by that. So we're based in Sacramento. So we don't need a volcano plan because that's not a community risk, but we have the highest flood risk in the nation. So darn sure our community risk would be, we want to make sure we have a flood plan. The other thing about the risk faced by your facility, so like maybe you're right next to a chemical plant. So what you want to do is make sure that you address, if should there be any kind of chemical release, and you have a better, you have a way of dealing with that. So that's what they're saying is develop a plan based on the risk faced by your organization. So do that annual hazard vulnerability analysis and look at your community's risk, but also your facility's risk, and then develop a plan to address those risks. The second thing that everyone has to do is develop policies and procedures. These are really geared towards effective response and recovery. And there's 4 policies. There's actually a total of 10, but they vary by provider type. So basically, in short, if you're an inpatient provider, you have higher amount of policies and procedure requirements, like sustenance and emergency emergency equipment and those kinds of things, versus if you're an outpatient provider, because you have less people relying on you. So policies and procedures, there's evacuation, shelter in place, medical documentation, and also use of medical volunteers. So those are the 4 requirements that everybody has to meet. And then again, it depends on your provider type. So if you're not sure, contact us. We'll be happy to share that information with you. The other thing that's a core requirement for everybody is, because we know in every disaster, we're all watching the news related to Hurricane Dorian, and communications goes down, power goes out. We know that. So that communications plan looks at how you communicate with your patients and your staff when disaster strikes, but also the external communication that you communicate with your local Office of Emergency Management, your local healthcare department, your local hospital, other facilities. You have to have a way of communicating with them and include in your plan. The last thing that everybody has to do in communications now, which makes a lot of sense, is to have a communications plan that you also have to have redundant communication. And everybody, as much as we think that our cell phones that are, at our sides at all times, that's redundant communications because landlines will always be up. No, that is not always the case. Oftentimes not. So that redundant communication is going to look different based on what your jurisdiction uses. So it might be satellite phones, it might be a ham radio, it might be ReadyNet, it might be walkie-talkies, it could be push-to-talk, whatever the kind of system, but you have to identify. So my homework for you all is, if you don't know what your local jurisdiction's using, because it has to be interoperable with them, don't just buy a bunch of things off. Oh, I'm going to buy a bunch of radios off of Amazon. Check my box, my communications plan. I have redundant communication. But if you don't know what frequency they're on, you're not trained on them, you don't know what to do with those radios. So that's where that redundancy is really important, that you have that well oiled. And then lastly is what we're mostly talking about today, which is the training and testing. So the requirement, which we'll talk about in greater detail. So, okay, so there've actually been some rule updates in 2017. A lot of people say, oh, well, once a federal rule comes out, we're good to go. Well, there's always change to these things. So in June of 2017, so the initial, it was finalized in 2016, and was told everybody by November 2017, everyone had to meet the 4 core requirements, as I mentioned on the previous slide. In June of 2017, we actually got some clarification before those requirements kicked in, what they meant by full-scale exercise. When many of you think, your connotation of full-scale exercise might be lights, sirens, blowing stuff up, 50 fake patients with blood and impalements in a triage, in a triage setting on your hospital parking lot. That's possible. That is a full-scale exercise for most. What CMS did is they actually defined and redefined what they meant by full-scale exercise. So we'll talk about that in a sec. So that was, and then November 2017, actually, and then in September of 2017, what CMS did is actually released a training on what the surveyors who are going to come survey your facilities, exactly what they're looking for when they come for your provider type. So you yourself can take that training. Highly recommend you do it. It's actually a really good training to reorient yourself about what those requirements are. That's the hot link there where it says September 2017. Take that surveyor training. It might be a good way to know exactly what they're coming to look for when they come to survey you. So November 2017 is when everyone had to have all the core requirements. And actually, when they come to survey, if you have not been surveyed as of yet, they're actually going to be looking for documentation that you've completed your exercises and hazard vulnerability analysis, and et cetera, and your plans going back to November of 2017. So that's a new thing. And then what happened was in September of 2018, there was a lot of pushback from a lot of provider types saying 2 exercises, that's a lot. I'm not really sure, do I really need that for my provider type? So actually CMS opened, asked for public comment on proposed changes related to the exercise requirements. That has not been finalized. But that was so you never quite know what the federal government, they put out proposed changes to rules all the time and never get implemented. For example, the initial rule came out in 2013, wasn't finalized till 2016. So we don't quite know. We'll stay on top of any kind of changes to your exercise requirements, but just to let you know that is a potential down the road that there might be a change. It might be different types of, what their proposed rule looked at was, based on your provider type, your exercise requirement would change a little bit. So, and then in addition, in February of this year, we actually have CMS now says, okay, you don't just have to plan for natural disasters like flood, fire, tornado, hurricane. You also have to add infectious disease and score that in your hazard vulnerability analysis and address it in your plans. And so it's just really important that people have good infectious disease plans. We also got clarification in 2019 about, you know, if you can count your exercise, if you've had an activation, you can count it towards your exercise requirement, but I'll get to that in just a sec. Okay, so what the training and plan testing requirements are is that CMS says you have to conduct and document. So remember the documentation, you don't write it down, it didn't happen, which is great, which is a thing. You have to training and test plans with up to 2 exercises. You have to do 2 exercises annually within every 365 days. So the training is you have to conduct and document initial and annual training. What that means is you all do new hire orientation. And when you do the new hire orientation, the issue is that you have to address and teach your staff what's in your evacuation plan, what's in what your emergency plan says. So you have to now, and then have a documentation of that. And then annually, many organizations have an annual in-service, you know, on what your plan says. But you now have to train that and document that. But it's not just with your staff. You also have to do it with your volunteers, your contractors. Let's say you're a community health center and you have optometry that is a contractor, or dental or mental health, or whatever those things are. You have to train your staff and document that as well. On the exercise, this is the question we get a lot about, and so it's a great opportunity to present this information, and as it leads well to the great shakeout is 2 exercises have to be done every 365 days. One has to be a community-based full-scale exercise, and again, CMS in the June 2017 interpretive guidance said that community-based full-scale exercise, and we'll talk about that. And then the other can be a second full-scale or a tabletop exercise. So moving on. Okay, so what does CMS mean by community-based exercise? So the good thing is CMS has not defined what community is, you know, but the goal is to provide that provision to ensure healthcare providers collaborate with each other within a community. So it could be 2 skilled nursing facilities. It could be a skilled nursing facility and a hospital. It could be public health and a community health center. It could be an ambulatory surgical center and a skilled nursing, whatever that may be, or ICF or home health and hospice. But what the point and really what the interwovings of what's and the underpinnings of CMS emergency preparedness requirements are is that if you know your disaster planning partners in advance of disaster, your whole community is more disaster resilient, because you're not just calling Jose at 2 in the morning and saying, Jose, you're going to call Jose because you just did an exercise with them 3 months ago. You're not going to be calling some random number out of Yelp saying, I need a bus to move my 67, nursing home patients out of my facility. You're actually going to be calling someone you know. So if you know each other in advance of disaster. And why CMS doesn't define community, because your community is very different. So whether you're in a very, very rural setting or very dense urban population, community is going to be looking differently. So there's a lot of latitude within that. The other thing is, if you've actually had emergency plan activations, not that we certainly want that to be the case, but with CMS, there is an allowance that organizations that have had a disaster plan activation are excused from the community-based full-scale exercise requirement for 12 months after the activation. And as of this year, with the Appendix Z release, if you actually had 2 activations in a year, you can count that toward and meet both of your exercise requirements if you document it. So that's a new clarification that we received from CMS. So that may be the case. Maybe you're part of the Ridgecrest quake or not, etc. But if you've had those activations and you've activated your plan, and ideally you activate your incident command system and your plan itself, your evacuation, whatever those things you activate, and you write an after action report, it can count towards those exercise requirements. Okay, so here's some tips on conducting a ShakeOut tabletop exercise. These are great, and getting specific to the ShakeOut itself is that you can test things such as post-earthquake patient movement. Do you have to evacuate those 67 residents out of your skilled nursing facility? Great opportunity. You can do this in a tabletop setting, which is discussion-based exercise. You can do it in saying how we're going to logistically, do we know where those 67 folks are going to go? Do we have memorandums of understanding with other community health, with other skilled nursing facilities that we can evacuate them to, or do we have to temporarily go to, do we have to go to like Charger Stadium, like they did after the fires in 2007 in San Diego, or oftentimes they use things like fairgrounds, and that's something for in your county. So your post-earthquake movement, how would you do that? What's the logistics? How many people do I need? If I have 67 people, how many of my staff and do I need to be able to do that? So you can do that, talk about the ShakeOut. So ShakeOut just happened, and then before the next, we have to quickly evacuate because we've had damage, we can't stay there, or out of power, etc. So post-earthquake and patient movement is a great thing to discuss in a tabletop. Evacuation itself, of like, how are you going to evacuate? Are you going to evacuate them from the facility, or maybe a part of it, or you're going to put everybody in the parking lot temporarily? What that looks like. Your emergency operations, how do you actually activate your plan? That you can talk about in a tabletop setting. Who's going to be in charge? Let's say you put the person that you think that, Mary Jo's always the one in charge. Well, Mary Jo's on vacation when something happens, and that's not going to help. So you have really opportunity to say, what's my incident command system like? What's my line of succession and succession plan of who's going to step in? Because Mary Jo, who knows everything, wrote the plan, has it in her head, can do all the stuff at the top of her head, isn't there. So maybe take Mary Jo out, have her be an evaluator or something, and see who else is going to step in, and how are you going to react. Your communication system. So like maybe you put your communication systems out of place. What else are we going to do? What are the other strategies we can do when the shaking stops, and we still need to, and communication is going to go out? What are you going to do? Do you have a business continuity plan? How are you going to activate that? Who's going to be in charge? Let's say you're going to not be able to be back in your building for 9 months because there's so much damage that has to be addressed. Triage protocols, those are other things that you can do in a tabletop. So things like how am I going to take those red, yellow, green patients, and who's going to take them? And let's say maybe can we take some of the worried well to another community health center? The hospital can move folks around. So those triage protocols you can all do in a tabletop. And then incident command, kind of as it goes back to the operations of who's going to serve as incident commander, and what does that look like? So all of this can be done in a tabletop exercise. The other thing is, what we like to do is you can actually add a functional exercise to your tabletop. So you're going to do the tabletop, you're going to talk about, there's been a small earthquake, and then you can, boom, it's now the aftershock, and it's even stronger than it was. Okay, everybody drop, cover, hold, and that you can do a functional element, and you kind of figure out in the building or in the office, or where you're presenting this information, like what would be a good place, and kind of talk about, well, that wasn't a good place because I could hold on, but I couldn't cover my head enough, etc. So you can add a functional element to your tabletop exercise. So as I said, I talked a little bit about this earlier, but the definition of a full-scale exercise, full-scale exercise, again, many people think, blowing stuff up, lights and sirens, and 100 patients, and every drama school student, for 3 counties in one place, and you all have to try to compete. That's not what CMS means here when they talk about full scale. They're saying it's not a Homeland Security exercise and evaluation, or HSEEP as many of us call it. It's not in a full HSEEP. And what that means too is that CMS is not as concerned about you don't have to use certain forms. They just want to say, did you do the exercise? Did you document it? Do you have findings? Did you update the plan based on those findings? That's the kind of simple things they're trying to simplify, but we know that the more and why these exercises are so important, and the ShakeOut is a perfect opportunity to practice this, is if you write a plan, the whole point of the exercise is not to just, get out of work for 10 minutes while you do an evacuation drill. No. Or a drop, cover, hold, etc. It's not what that's all about. The whole point is finding plan gaps. And it's an opportunity to really find, and kind of, as I talked here in a few slides, of really saying, do we really know, is our plan really going to guide us on how we're going to evacuate those 67 skilled nursing residents? Probably not. Okay, we need to update our plan to find where those gaps are, and update the same to make sure we know what to do. And again, CMS defines any operations-based drill. It could be a functional exercise. You want to do a full scale, great. If you just want to do a drill, but you actually have to physically do something that assesses your functional abilities by simulating a response, like let's say if you do figure out you're going to evacuate after you've done the hold on, the shaking stopped, let's say maybe one of the building exits that you're expecting to go out, maybe there's debris and you can't go there. And maybe you're going to say, well, our assembly point is in the parking lot. Well, that might not be big enough because we are sending 30 people out to the parking lot, and the parking lot can only hold 10 people. So it's an opportunity for you to go, oh, well, I need to update my evacuation plan to figure out an alternate route. Okay. And if you want to do the ShakeOut exercise, and how you can counter your full scale exercise requirement. So one thing that we're a big fan of is coordinate with others in your community. We think that that's really important. Again, it helps to meet that community-based requirement so you know each other in advance of disaster. Physically evacuate your facility is always good. I know there's a lot of logistics involved. So this is not something you can do, the day before and go, oh yeah, we're just going to evacuate. No, it takes a lot of planning. Activate your emergency plan and incident command team at your facility. You might want to pull on your vests. You have an incident command, team charts, whatever that may be. So think about that. Communicate with other facilities about the possibility of moving clients and patients or residents to other facilities, and maybe saying, we're going to practice, like, oh, by the way, I'm a skilled nursing facility. I'm going to call my, fellow community health, skilled nursing facility half a mile away who I know. Hey, by the way, we're doing a drill right now, and we want to see, could you take 20 of our residents? The answer may be yes or no, and then maybe that you're going to say, okay, maybe we have to figure out, do we need MOUs with more facilities, memorandums of understanding, etc. So evaluate your exercise based on your objectives. You've set up the objectives. You don't just go, okay, we're going to just do this and it's going to be over in 5 minutes. What a lot of people do is when they do those exercises and it's over in 5 minutes, all you're literally doing is telling, you're practicing walking out of the building. You really want to make it harder. You're testing your plan, not your people, and really to find those glaring gaps that you can update based on your findings. Document an after action report, and then that improvement plan that you put together is really key. The other thing that we're huge fans of is your healthcare coalition. This is a link, hot link, to all the healthcare coalitions in the country. They're great sources because many of them have community-based exercise requirements. You might meet other CMS providers you didn't know already. Again, knowing each other in advance of disaster has helped your community be more resilient. They're organized a little different. Sometimes it's your health department, sometimes it's the largest hospital, maybe it's your EMS agency, maybe it's law enforcement that's involved, but it's a group of individuals, hospitals, EMS, etc., working in a geographic link. You know, I know, for example, in South Dakota, there's only 4 in the whole state. You know, that's a big swatch. It just depends. Many of them have these exercises. They also host annual trainings and exercises. So these are just a few. The Santa Clara Valley Emergency Preparedness Healthcare Coalition, Wyoming Healthcare Preparedness, Northwest Response Network. So if you're not sure how to find them, you can go to that link. And if that link's not helpful, I highly recommend asking your largest hospital, EMS agency, or public health, and they'll tell you. Where those meets are. The other thing is, do not wait for an engraved invitation. Find out when those meetings are, show up, because it's going to help you meet those exercise requirements. They might do training on incident command. They might be able to review your plans. They won't write your plans, I'll tell you that right now, but they have a ton of resources. So go to your healthcare coalition. Okay, so here's the question. One of the things that we had is, during the live session, we said how many people had your survey as of yet, and only about 25% of people responded they had. So what that means, it's a big, large swath of people that have yet to be surveyed. And what we want to say is, you haven't been surveyed yet. They just haven't gotten to your number yet, and they certainly, and certain providers get surveyed at different intervals. Like skilled nursing tends to be like every less than 18 months, and hospitals every 3 years. You know, it just depends on your provider type. So if you haven't been surveyed, you are not completely off the hook. You will get surveyed at some point. Okay, so that's our presentation. We did have a number of questions that come in, and so Teddy's going to share with us some of those questions.
All right, Mark, these questions are for you. The first one is, for years we have been told to stand in a door jam. Can you discuss why this is no longer recommended?
Yes, and it actually hasn't been officially recommended for many years. And the drop, cover, and hold on protocol has been the official advice since the 1980s. What happens is people have learned things and may not hear the new recommendations, and that has been told to each other and kept in our memories. But the reason why that really should never have been the recommendation is it does not protect you from the main reasons that people are injured during earthquakes, which is falling objects or flying objects. That being under a maybe 4 or 5 inch doorway is just not sufficient to protect you from such things. It also is dangerous to try to stand during an earthquake because you could be knocked down. You are not strong enough to hold yourself in the doorway when the shaking can be very strong. And also, if you're in a room with a few people and there's only one door, there may not be room for everyone. And also, if you're in the door, your hands are on each side of the door, and somehow the door gets closed, you might have your hands and your fingers injured. Those are some of the basics. The reason why it was originally suggested is the idea that, oh, the wood around the door frame is more strong. It will remain standing while the whole building crumbles around you. And that is also, if you really think about it, unlikely that 4 or 5 inches above you is going to protect you as the whole building falls down. And that's just also, by the way, fairly rare. So that's why we recommend to protect yourself from falling objects by getting down low, making yourself small, getting under something if possible.
Okay.
Okay. When traveling from patient to patient,
Hold on, let me reset that.
When traveling from patient to patient, what is the best option to keep safe in a vehicle during an earthquake?
Yeah, so I guess this is perhaps for traveling healthcare providers, home care providers and such. And yeah, so and whenever you're in a car and being an earthquake happens, first you may not even notice it because your car's suspension and shocks may not have the earthquake shaking travel to you, but you may start noticing people around you reacting. In a large enough earthquake, you'll feel as if your steering is gone out, you're bouncing around a little bit. You really just want to stop but be present to your surroundings. Don't just slam on your brakes and cars are behind you. Pull over, stop your car, turn it off, put the parking brake on. It really is just to make sure that your car isn't rolling still and of course bouncing around. You want to be out from underneath any overpass of a bridge and just be aware of your surroundings again. And then you basically ride out the shaking. You don't need to drop, cover, hold on inside your car. And the only other situation that might be if you are under a bridge or in a tunnel or something that you might lean over in your car just in case that something does fall on top of your car, maybe collapses the roof, you're lower enough down to where you'll be all right. That's very rare and very unusual.
All right, the next one is, we are a day surgery facility. If an earthquake hits while the patient is under anesthesia in the operating room, how do we protect them? Do we move them?
That's a good question, and it really can be extended to what to do with patients generally. And if patients are in a bed and not able to move on their own, and certainly if they're under anesthesia, they're not able to move, but really just in general, our recommendation for people who are in bed in general, not even in a hospital or healthcare situation, is to stay in bed, because getting up and moving, again, is not recommended. Getting down next to the bed is not recommended because of potentially a broken glass and things that might be there, but also because what you want to have done is secure the environment around the space of the patient so that there really isn't things that are going to be falling on them. We also recommend that healthcare providers and really anyone protect themselves first during the shaking so that they are then able to provide assistance after the earthquake stops. It is very difficult for people who are caring for people to think that way, but you don't want your patients to have to somehow come to your aid because you have been injured, you have fallen, and or an unlikely situation, probably where you had shoes off, unless you're a home care worker, that you would have broken a glass that you stepped in. But overall, we do not recommend that you move patients because you really don't know how big the earthquake's going to be, and by moving them, you may cause injuries that then the earthquake didn't really need them to have been moved. It wasn't strong enough shaking. You really just want to make sure that there aren't things that are going to fall onto them where they are. Protect yourself and then come to their aid.
All right. Our next question is, we are a skilled nursing facility. When would we evacuate this facility?
So evacuation is a judgment call for all groups, if whether it's needed or not. We do not recommend automatically evacuating after any earthquake. Earthquakes can be of many sizes, and you might feel shaking, and it might be unusual in your area, and you might be very concerned that, oh, is the building very damaged? But really, it's only going to be very strong shaking, certainly where you have a lot of things that have fallen. I'm not talking about a book that's fallen off the shelf, but really everything falling over to where you're really going to be concerned about the building. There may be other issues that you will require evacuation, whether it's broken utility lines within the facility, water or gas, or Of course, if there's a fire that's broken out, of course, you want to move people. And if there's noticeable damage to the structure that is of concern. Some groups will evacuate because it's part of their overall emergency plan to have people exit so that they can take roll call, so that they can really have a sense of all that happened, get reporting to in a centralized place. And with that roll call, identify if there are people who have not exited. And at that point, be able to do perhaps some search and rescue with staff, or direct emergency authorities when they arrive that there are some people who are missing. Really, that depends on the level of training of your staff for doing such rescue and their knowledge of whether the building is appropriate to go back into or not.
All right, the next question is, what do we do to protect ourselves and 82 mentally and physically wheelchair-bound people?
In my presentation, I did talk about how people in wheelchairs and other mobility assistant devices can protect themselves. But of course, that has to, that's information that you can give to people, but you can also practice with them. You can inform them in the moment about what to do. So literally from your safe space, yelling out, stay in your chair, lock your wheels. And that can work for some people. You might need to, depending on mental abilities, you may need to adapt that messaging or practice other approaches. I should say that people practice drop, cover, hold on and earthquake safety as young as 2 years old. It's not necessarily described as when an earthquake happens, this is what you do. For young children, it is adapted to say, pretend like you're a bunny and you're being chased by the wolf, and you got to get into the hole in the ground where you live. And so teachers say, bunny in the hole, and they'll run. They'll know that's what they're to do, and it becomes a game. Now you can adapt that type of approach depending on your clients and their abilities. And so you don't have to explain necessarily what earthquake means and all the details, but you just want to find a way that works and then practice that with them. So, and then of course, practice with your employees what to do and how to provide that information in the moment. What we really still don't encourage is for employees to be putting themselves in greater risk in assisting their patients or clients. You want to make sure things are not going to be falling on them in advance, and you want to have this practice. What ShakeOut is about is practicing in advance so that the right behaviors can be done when the earthquake actually happens.
All right, and this is the very last question for you, Mark. The parking lot at our center is covered with a solar panel. Is it safe to transfer patients out to that area?
It's an interesting question. Buildings are built to codes that are meant to save lives. Doesn't mean the building won't have a lot of damage, but the newer building codes are meant to prevent death and injury in earthquakes. It may not be usable afterwards, but people won't be injured as much as, with the right codes. The solar panel that are being installed in many parking lots may not be to that same standard. They aren't a building. There typically aren't a whole bunch of people there. People are coming and going, but they're not just staying in their cars. And so the life safety aspect of that may not be as good as the building next to that structure. So you want to be educated on how those solar panels have been installed and if such aspects have been factored in. And then if that is your only area that you can evacuate to, make that judgment call.
All right, thank you, Mark. All right, this question is for Nora. What is a disaster plan activation?
Very good question. So when disaster strikes, you have a plan. One would hope, at least CMS intends you do, because they're going to come survey you on it. You actually have a plan that says what we do when something happens. It's not out of your normal day. It's something happens. You're going to have your try to get out of the building if you possibly can once once the shaking stops, etc. But your plan's going to activate, which will mean all of your response activities that you've said in your, let's say, your earthquake response plan of who's going to be in charge, what are you going to do, who's going to do damage assessment, who the roles and responsibilities are. So all of those questions are answered in your activation when you activate. And the whole point is the more you test of that, the more you practice, the more your staff have muscle memory, and so they know what to do when something does happen. So ideally in this case we're talking about an earthquake, but it could be use that same activation, whether it's a flood, hurricane, tornado, etc.
All right, our next question is, can home health agencies communicate or have drills with doctors' offices and be considered as drills?
Yes. So again, CMS does not define what community means to you. You determine that. And the more that anyone that ideally you want to be drilling with someone that's going to actually help you in disaster. What we all know is because you serve these populations, you probably are already community oriented anyways, and you're going to step up. So you're going to train, you're going to address your internal response, but also be part of the community-based response. So, think about conducting drills with organizations that you need to have a relationship anyway. So whether in that case, it's going to be primary care, that works well, because that's someone that you're going to have to be interfacing with during disaster anyways.
Next question is, can you conduct your tabletop exercise right after your full-scale exercise during the shakeout?
You can technically do it. It's really not required. It's really not recommended. The reason is the whole point you generally want to do 2 exercises in a year is the intent is for you, and Mark, you're welcome to weigh in on this as well. The ideal is that you do a tabletop exercise, you address what some of the logistical issues are, you update your plan based on those findings as a tabletop, and then you do it as a full-scale exercise, and then you're going to have even more findings because you're testing more of your plan. You might be testing your communication system, testing your incident command, or testing evacuation or shelter in place or whatever those procedures are, or the earthquake drill requirements. So whatever that may be, but the ideal is not to just get it done in one day. The whole point is finding those plan gaps. So while it's certainly doable, it's not recommended. Mark, anything to add?
I don't.
Yeah, okay, great.
If we include patients, their family members, and any other persons who are in the facility, and we give them information and forms to everyone, would that count as a community involvement? I'm guessing for a community-based exercise.
What they mean by that is you have to drill with other organizations. So it could be skilled nursing, it could be law enforcement, it could be your EMS, emergency medical services. So it's not just the community drill. The intent is for you and another organization to decide what kind of response and what you guys would do to respond to a community-wide event, rather than just involving your patients. Although it's a good idea to involve from patients, it just takes a lot of advanced planning. Not a bad idea to do that, but it's not going to meet the community exercise requirement. It's for them, to organizations, to interface.
All right, our last question for Nora is, how do I take this self-assessment, and how does it relate to my CMS emergency preparedness compliance gaps?
Okay, good question. So we included, and also in the link, which I'll show you in just a sec, we have here, I think it's on here. Here we go. So It's a little bit about Connect Consulting Services. We women owned, obviously we're a national firm. Our goal is to make you meet the CMS exercise requirements and planning requirements for sure to be compliant and develop a program that's compliant, but also makes your organization more disaster resilient. That's our larger goal. You know, it's very similar to what Mark was saying is about, yeah, it's great that you know about it, but now you actually can make, so you understand and implement those disaster resilient activities. So we'll send you a copy of the recording. Everyone will get that. We have here a self-assessment right here in this hot link on our website. So you can learn about what your compliance gaps are. So what the gaps will say is, have you conducted your exercises? When were they conducted? How recently? Who was involved? Those kinds of things. So the whole point is understanding what the requirements are and where your organization's gaps might be. You might have planning gaps, or you might have, well, we have a plan, it hasn't been updated for a while, but we don't do our exercises. So it just gives you a roadmap to figure out what your priorities are, where to start, and how to fill those gaps. We also are doing another webinar in September. We're doing it on policies and procedures and talking about evacuation, alternate power, and food planning. So for those of you that have those sustenance requirements, so you can go straight to that hot link and access that webinar and sign on up. We also have a monthly newsletter if you want more information about tools and strategies and how we can help. We also have support for having you meet the compliance requirements in a coaching program. So if you want, you can go straight to our website and learn more about that. We have a very detailed CMS compliance toolkit, on-demand content, live calls, and a guarantee you're going to pass your survey. And this is my information, a little bit about our organization. We really appreciate you joining us today. Mark, thank you so much for your really comprehensive content. It's just really helpful to hear that we have great support. And our goal, I'm sure you join me in saying that we want as many healthcare organizations as possible to continue ShakeOut, because not just to meet the exercise requirements, again, we want to make sure you're disaster resilient as well. Any final words?
That's right, Nora. Thank you so much, and for what you've provided for hosting the webinar. And it's been really exciting to see so many more healthcare participants participating in ShakeOut. The number of organizations has more than doubled in the last 2 years. And so that's why we wanted to bring this information to all of you to know how to participate and make the most of it so that it can satisfy your requirements.
Great. Well, thank you very much, and look for information in the future from us and see how we can continue to help.